3, 2, 1, go.
Good evening, ladies and gentlemen. Today, I'm going to we have arranged the webinar on women and COVID-19 correlation and causation. I'm Dr. Nazish Butt. I'm consultant gastroenterologist at Jinnah Postgraduate Medical Center, and I'm also associated with Aga Khan University Hospital and National Medical Center. Currently, I am the General Secretary of Pakistan GI and Liver Disease Society and the Publication Secretary of Pakistan Society of Gastroenterology. So we have arranged this seminar, and we have very esteemed female gastroenterologists from all over the world, and they will join us and they have presentations regarding COVID-19 and role of women. And first, I would like to ask Dr. Lubna Kamani. Dr. Lubna Kamani is one of the female renowned gastroenterologists of Pakistan. Currently, she is working as Associate Professor of Gastroenterology at Liaquat National Hospital, Karachi. So, Dr. Lubna, can you please shed some light on this webinar, COVID-19 and women?
Thank you, Dr. Nazish Butt, with a very nice introduction. I welcome all the international and national speakers for joining me basically in this webinar on a very important topic. Being a Vice President of Pak GI and Liver Disease Society and Executive Council member of Pakistan Society of Gastroenterology, and being a part of Big NAP and representing Pakistan, I thought that this is the time that we should talk about women and COVID, because as we know, that as we are moving forward in this pandemic, we are learning that this virus has negative impact, socioeconomic as well as economic as well as mental on women. But on the other side, on the clinical side, it has a positive effect with low mortality. We have also observed through media, through TV channels, through publications, that where there is women leadership, there is effective control of this virus. So just in order to shed light on this topic, are these all baseless? Is there any evidence behind this? Is there any research behind this? So I thought that it's high time that we should conduct this webinar with wonderful, educated women around the world. So I gathered all those women and I asked them, and what we all felt, that it's high time that we should conduct women and COVID correlation and causation, so that we can talk about evidence-based and literature-based, and we can become more wise in this topic.
Thank you, Dr. Lubna. Today, we have very esteemed panel of gastroenterologists with us. Let me introduce them. We have Dr. Amrita Sethi. She is Associate Professor of Medicine, Director of Interventional Endoscopy, Program Director, Advanced Endoscopy and Fellowship, and Division of Digestive and Liver Diseases, President of Women in Endoscopy in New York Hospital, NYSG, New York Hospital. And we also have Dr. Nonthalli Pasoveli. Dr. Nonthalli is a famous gastroenterologist of Thailand. Everybody knows her regarding the EUS and EM. She is very famous in Pakistan regarding the ERCP and EUS fellowships. And we have Dr. Payal Saxena. I don't know if Dr. Payal have joined us or not. Dr. Payal Saxena. She's also Professor of Gastroenterology in Royal Prince Alfred Hospital, Sydney. And we have Dr. Simone. She's GI endoscopy research physician at Brazil. So I would like to start our webinar with the first presentation. For the first presentation, I would like to invite Dr. Sharmila Sachithanandan, and she would discuss regarding women leadership and effective control of COVID-19. Dr. Sharmila is also a very renowned female gastroenterologist of Kuala Lumpur. She's working in Kuala Lumpur, Malaysia. So Dr. Sharmila.
Hi, everyone. Can you hear me?
Yes.
Great. Well, I would say good evening, but it's actually morning somewhere else. So hello will have to do. Thank you all very much for this invitation, especially Lubna and the Pakistan Society of Gastroenterology and Hepatology, as well as the Medical Microbiology and Infectious Diseases Society for Pakistan. I certainly am very honored, and WIGNAP is definitely privileged and honored to be part of this collaboration. I think we have very limited time for each talk, so I will quickly move on. My talk is on women leadership and the effective control of COVID-19. So early in 2020, the beginning of this year, an invisible, highly contagious, deadly enemy was fast approaching. Leaders around the world faced an unprecedented test: what to do, how to prepare, and how to respond. This moment in history offers a unique opportunity to understand the consequences of leadership decisions in a high-stakes situation. Strategic preparedness and response plan was necessary. For the effective control of COVID-19, 3 factors emerge as having a significant impact on the spread of the disease and ultimately the deaths. Number 1, population density. Number 2, exposure to those who traveled. And number 3, the date when things were shut down. The shutdown date has been shown to be directly related to the actions taken by leaders. Cities, states, and countries that implemented a clear, thorough, and well-executed social distance plan at least a week before their first death had radically different outcomes. They managed to flatten the curve, control, and prevented new cases. What do these women have in common? These women took swift, decisive action to fight the pandemic. They led their countries to go hard, go early, in the powerful phrase of Jacinda Ardern, the Prime Minister of New Zealand. They carried out costly interventions at great political risk. They had aggressive national testing and contact tracing programs and tough restrictions on social gatherings. They communicated clearly and forcefully, and they were more concerned about keeping their citizens alive than their slowing economy, revealing their feminine compassion and survival instinct. So lives before livelihood. And the Taiwanese president, she introduced more than 100 public health measures in January, very early on, even when WHO was still casting doubt on the possibility of human-to-human transmission. So resilience, pragmatism, benevolence, trust in collective common sense, mutual aid, and humility are mentioned as common features of the success of these women leaders. I'd like to share with you 6 leadership qualities that these women displayed. So number 1, deliberateness. So Michelle Obama actually mentioned this, that men can repeatedly blow it and they still get a second chance, whereas women can't. So they really think about what they have to say and do. They're very thoughtful, intentional, and deliberate about how they lead. Number 2, humility and inclusiveness. So women have been shown to be more willing to listen to advice and to include different perspectives when they have to make a decision. So all these women leaders, they listened to their scientists, they listened to their public health people, they listened to their infectious diseases specialists before they made decisions, as opposed to some who only listened to people who would agree with them. Number 3, communicativeness. So they took care to clearly, consistently, and effectively communicate to people what they were doing and why. They were transparent and there were frequent updates. Empathy and compassion. Again, Jacinda Ardern really stands out in her Be Kind statement, which really inspired many acts of charity around the world and especially in New Zealand. And the Be Kind is a national slogan on many billboards around the country. The Norwegian Prime Minister, she took time to have a special conference for children So she, was just mainly for kids, no adults invited. She got down to their level to sort of, tell them not to be scared and to tell them what was happening, which was really quite unusual. You don't see leaders doing that, prime ministers doing that quite often. Decisiveness. So shutting down the economy early was a risk-averse strategy, which was necessary to just protect life first. And many of these women acted first. They made that bold, unpopular call to shut down life. And finally, resilience. That's absolutely necessary quality. And in contrast, what do these men have in common? These men downplayed the risks of the virus until it was too late. Their government delayed lockdowns and other crucial protective measures. Their inability to see risk had dire consequences and high death tolls, and they seemed to rely primarily on their inner circle and not really taking the perspectives of many outside who could have helped them get better advice. And their hyper-masculine style lacks humility and empathy. However, it is unfair to say that they're representative of all male leaders. I think globally there have been some male leaders who've done an incredible job, like Australia and South Korea. But I think what is of, staring right at our face is that these three men, their politics are somewhat right-wing and populist. And they're leaders at many levels for women, not just politically, at the workforce, frontliners, at home. And there are few women who have done a lot of incredible things in this pandemic, but they haven't probably got the right acknowledgement. For example, the health minister in Kerala, she was a secondary science school teacher, and she's done an incredible job in India. In her state of 35 million people, the death rate is extremely low. I think it's like a single digit. And she's a national hero. She has had some experience with the Nipah virus, and she basically instituted all the WHO protocol very, very early, even before the first case turned up in Kerala. And I think the same goes for the Prime Minister of Sint Maarten. It's a very small island. But she knew that, her resources were limited. She had only 2 ICU beds. So she basically told all her people to stay at home. And South Korea's CDC chief, she's a national hero as well for all her work that she's done during this pandemic. So as Soumya Swaminathan, who is the chief scientist at WHO, she said that this COVID outbreak has given us the opportunity really to spotlight the unrecognized role of women in many areas. And apart from all that, these women are breaking stereotypes. When we think of a leader, we think of male, aggressive, forward, domineering, but these women have shown that a softer, more humane leadership seems to work better in this crisis. And is there a need to dress to impress? I think all of us are kind of half clad in our pajamas now, but New Zealand's Prime Minister showed that just staying in her tracksuit and on her sofa, live streaming, we are all in this together, really took to many people. Danish Prime Minister shows us that she's being real, letting her hair down on a Friday night. There's a video of her and her partner washing dishes and singing. And the other interesting thing is that all these women are young. They are in their late 30s and mid 40s, and that's really breaking the stereotypes. Now, a couple of words on the glass cliff. This is something new to me. I've heard of glass ceiling, but when I was doing this research for this talk, I came up with the glass cliff. And this is something the business world is quite aware of in the corporate world. And this applies to a situation where highly qualified women are asked to lead only during periods of intense stress and times of crisis when the chance of failure is high. So when leaders are needed to endure the crisis, be responsible for the crisis or to manage people through the crisis, people preferred feminine leadership qualities over masculine ones. Women are at risk every day, so we see it differently, we assess things differently, and you act in the face of it differently. And I guess the various difficulties women encounter due to bias, stereotypes, work-family balance, other social, historical, cultural factors, all that has helped them to cultivate certain leadership qualities that are now serving them well during a crisis. And really this applies to anyone who has struggled against disadvantage and has made it. These people are better, stronger, and more skillful. So COVID-19 shows us that it's about high quality, life-saving leadership. Are the leadership skills of women underutilized for the benefit of society? I think so. Female leaders have a better opportunity to be elected into power and trust in progressive societies. What this means is it's not just the women leaders, it's the societies that have picked them and entrusted their lives in women to run their government. So those people, it's them who have basically made the situation such that these feminine qualities have led to better gender balanced environments that produce more robust decisions. And what's interesting is that this year's Global Gender Gap report also shows that the countries that have fought this pandemic quite well have been led by women. And if you look at the top 10 countries, Iceland, Norway, Finland, New Zealand, Germany are all there. All is not that great. According to the gender report, gender parity will not be attained for the next 99.5 years. And according to this Women in Global Health report, we know that women make up the majority of frontline workers, more than 70%. Yet, at the table, when it comes to decision making, less than 1 in 5 experts are female. Similarly, this Global Health 50/50 report shares the same sort of information that at the top level, at the Global Health Organization's top level, 70% that make decisions are male. Again, organizations also, in terms of being gender responsive, they're all like less than 30%. The effect of COVID on women, this is getting to be the new normal. So we now know that it is possible for both men and women to work from home. But I think women are facing far more challenges than the men as a result of the prolonged quarantine. Women have insecure labor. Even when kids are homeschooling, they have to bear the brunt of that and care for the sick and elderly who are at home and not able to make it to the hospitals. Globally, there's an increase in domestic violence, I think everywhere. So women and girls are not really safe, even in their own homes in some places. And basically, any pre-existing inequality will be amplified during this pandemic. School closure, online teaching, this would affect women and girls because they are less likely to have access to education as well. And unemployment is definitely going to be on the rise and will hit women more than men. So we do need more women in leadership. We know that women have played a central role in this pandemic. We know that women comprised of majority of the world's frontline, more than 70% shouldering the burden. And in China itself, more than 90% of the nurses are female and more than 50% of the doctors are female. 70% of the world's healthcare staff are women, but only 25% of global leaders are women. And women world leaders are less than 7%. Leaders are important because they dictate where funding and research goes. And without women in these positions, a lot of issues could be failed to be addressed. Numerous reports have highlighted the conspicuous invisibility of women and gender in global health governments, and there is an urgent need to increase the representation of women in all positions of influence. And finally, my last slide, I guess at the end of the day, whether women are intrinsically better or not, it might be more productive to look at the qualities that these female leaders are displaying for essential crisis leadership. These same qualities can help leaders in business, male and female alike, to also lead effectively in crisis. With more women and diversity on board, there is a broader perspective on crisis, and power is enhanced by the contribution of everyone. This corona crisis is global, it may be long-lasting, however, it offers an opportunity. And if given an opportunity, women can do very well and benefit the world. And this really applies to every human being, regardless of gender, race, or religion. So I believe that the key is equal opportunity and diversity, which will help us to progress. Thank you. Special thanks to my friend, my best friend in Singapore, who's a freelance writer, and my husband who helped me with the input of putting all this together. Thanks. You all hear everything? You're muted, Nazish.
Dr. Nazish, I guess you have to press the button. You are mute. Thank you, Dr. Sharmila, for very enlightening talk. Where highlighted very important topics, and there were few points that I did not know. I'm happy that your husband actually gave you a few tips, and being a man, he's helping you to form women leadership. So claps for your husband, basically. Nazish, are you here?
Yes, I am here.
Okay.
Thank you, Dr. Sharmila. Very nice presentation. So I would request the panelists, if they want to ask some question from Dr. Sharmila, 2 or 3 questions, or they want to give any comments. So if there are no questions.
I guess, Nazish, there is one question from Simone. And
yes.
what she's asking is, do the women professional backgrounds shown here have any similarities? So Sharmila, this is the question from Simone. I repeat, do the women professional backgrounds shown here have any similarities?
I was just talking about the leaders, and they are mainly all the prime ministers of the various countries. And I think what is unusual is that there are very few women prime ministers, and what's stuck is that these women have done very well in this pandemic. And I think there are a lot of articles on why they're doing well. And in terms of their exact backgrounds, I can't answer that question, Simone. I didn't really look into where exactly they came from. But obviously, they are young, they are bright, and they are willing to listen, and they communicate very well, and they're empathetic, and they have all those fantastic qualities that I think future leaders will need to make sure they have those, and not just in times of crisis as well.
Sharmila, I was wondering about this, because I was asking myself if some of these qualities that you have very, very well highlighted come not only from our female backgrounds and brought up, but also because we walk in a way of our formation as professional and person that may make us reach this result of having these qualities in mind. So I was wondering, what is the key between and the balance between personal backgrounds and professional backgrounds that could, like, we could highlight also that maybe would make good leaders? Was this that's why I was asking this. Thank you very much.
Yeah, very good point. I think, for these leaders for these women to get to that point, it would not have been easy for them. And if you look at that glass cliff slide, I think a few of these women became prime ministers because they just happened to be there at that time when there was no other right person. You know, so that opportunity came up when there was no better person. It was not like they could just go for that job and get it. Does that make sense?
Totally. And also the recognizing that because we have so all of us, and looking to these difficulties as good opportunities to learn and to develop, maybe this is what is underneath everything, you know, the way of looking things.
Yeah.
Thank you
I
again.
think.
Okay, so we like to move towards the next presentation. Our next presenter is Dr. Bushra Jamil. She is Professor of Internal Medicine and Infectious Diseases at Aga Khan University Hospital, Karachi. And she's also the President of Pakistan Medical Microbiology and Infectious Diseases Society of Pakistan. And Dr. Bushra will discuss on the mortality difference between men and women and insight regarding the COVID-19 infection. Dr. Bushra Jamil.
Okay, thank you very much, and thank you for this invitation. I think it's a very important and timely topic which should be highlighted. So I'm going to talk about mortality difference between men and women and insight. And we all know that COVID-19 is, in a large majority of cases, a mild infection. And there are several factors which have been shown to influence disease outcomes. It has been said that COVID-19 does not discriminate, but this is not true because now it is being increasingly shown that people have different outcomes based on their class, race, pre-existing health status, and geography. And all these factors make some people more vulnerable as compared to others. People living in denser urban areas or working in close proximity to others are more likely to contract the virus. And existing inequalities in conditions like hypertension, diabetes, etc., may magnify the impact of the virus in certain groups. So older age and presence of comorbid conditions have been shown to be associated with higher mortality. Males have been shown to have higher mortality if they get SARS-CoV-2 infection. So how is gender influencing disease outcome? So it could be the result of genetic factors like expression of certain genes, interplay of hormones, receptors, cytokines, and ethnic differences. Economic factors may be important. Certain occupations are associated with higher mortality. And then there are psychosocial factors, behaviors and habits, and where men and women can differ substantially. So men and women both have similar odds of contracting the virus with certain exceptions across countries. In some countries, women actually make up a majority of cases, whereas in others, men do. But men face a higher risk of death than women uniformly throughout the world. So this is data from New York City, which shows higher numbers of cases, higher numbers of hospitalization, and higher mortality. Similarly, if you compare different age brackets, so the largest difference you see in mortality is between men and women at younger ages. And as the age advances, this gap tends to close. So data from nearly 20 countries suggests that the risk of death in men is 2.4 times higher, regardless of age. And older men, especially those with underlying diseases like diabetes, hypertension, COPD, and so on, are more vulnerable to death as compared to their female counterparts. Again, this is mortality data from different countries, and you can see that 68% of deaths have been in men in Italy, 64% in China, and so on and so forth. So preponderance of males dying of COVID-19 as compared to females. I think I have the wrong slideshow here. So if you can just excuse me, I would like to put on the other one. Just a minute. Sorry about this.
So we have some technical issue with Dr. Bushra Jamil. So if anybody from the audience want to ask any questions, as we are going live on Facebook, you can ask questions from our expert panelist.
I'm going to ask this Sharmila. That was an amazing talk. And, I think one of the challenges, how do we translate now this fantastic display of women leadership that happened in a very, in this crisis moment, as people emerge from their homes and re-enter their business and their livelihood and schooling, how do we sort of carry this forward into a society and into our lives to make sure that it sustains the recognition of women leadership? And any thoughts on that?
After this pandemic, I was actually hoping to have women groups, because it speaks for itself. You just look at the TV and the frontline women and their families, and even their families at home to go to work and put themselves at high risk. It's an incredible time that you see men and women working from home. The impossible has become possible. It is, and I think it's girls, the young women, to see that it is all possible. It's happening. It is possible. It shouldn't be difficult, and to fight for your rights, to have that opportunity. I think it's all about ensuring that they just get that opportunity to prove themselves and get that spot.
I think so. One more thing, that we need to write it up more so that it is more evident, the palest ink is the better form than any most retentive memory. People will tend to forget.
Sorry, Dr. Lubna, Dr. Bushra Jamil is back, so we have running short of time. So we would like to continue with the presentation. Dr. Bushra. Dr. Bushra, are you starting your presentation?
Yes. Can you see the slides?
Okay. Yes, we are seeing.
Okay, so I just want to share some data from the Aga Khan University, because I don't have the national data on difference in mortality between males and females. So I just selected this slide. During the initial few weeks, we had around 66 COVID patients, and all the deaths were amongst men. So none of the women expired and they all survived. So let's take a look at genetic factors which may be having an influence on why women are doing better. And there may be a difference between gene expression, hormones, receptors, cytokines, and ethnic differences. So one gene which has been proposed as playing an important role may be the TLR7 gene, which encodes for a protein, which actually provides innate immunity against RNA viruses like coronavirus. And this protein is expressed because the gene is located on the X chromosome. The protein is expressed at twice the dose on many immune cells in women. So the immune response against coronaviruses or other RNA viruses is said to be probably amplified in women. The other important factor is the angiotensin converting enzyme 2 receptor, which mediates entry of virus into the cell. Now, these receptors are ubiquitous and they're expressed in heart, blood vessels, kidney, brain, and testes. The receptor is also abundantly found in the GI tract, throughout the GI tract, and both the COVID disease diagnostic tests and pathogenesis and clinical manifestations can be related to the richness of organs where ACE2 receptors are present. So ACE2 receptors are present in testes, and the virus has been detected in semen from a small number of men whose semen was tested for COVID, and all of these patients had confirmed COVID-19 infection. So this question has been posed: does the virus hide in testes? So men seem to clear the virus more slowly as compared to women. And the questions are, does the virus actually infect testicular tissue? Are testes serving as reservoir of SARS-CoV-2? And does local replication lead to higher overall viral loads in men and therefore likelihood of more severe disease? So all these questions remain to be answered. The other important question is that of levels of pro-inflammatory cytokines. So levels are higher in severe disease and are responsible for the cytokine storm. In one of our previous studies, we found that IL-6 levels were higher in sepsis-associated mortality in males. So is this phenomena also going on in SARS-CoV-2 infections? We don't know. Let's take a look at the role of ethnicity, occupation, and socioeconomic conditions. So reports from UK, Finland, US, and other countries are suggesting that non-white ethnic groups have been worse hit by SARS-CoV-2. Especially in UK, men of Pakistani and Bangladeshi origin and Black people are twice as likely to die from coronavirus as compared to their Caucasian counterparts. Even women from these groups have higher chances of mortality. However, individuals from the Chinese and mixed ethnic groups have risk of mortality similar to Caucasians. So without adjusting for factors including poverty, education, and deprivation, etc., the statistics department of UK found that Black males were 4.2 times more likely to succumb to COVID, and women also had a higher risk of death. So there is an interplay of several factors. If you look at occupation, men working in the lowest skilled occupations overall have had higher death rates, and these include security guards, bus drivers, sale assistants, and construction workers. Healthcare workers, however, did not have a significantly higher death amongst males. So the mortality has been similar in both male and female healthcare workers. However, healthcare workers working as home carers had statistically significantly higher death rates with COVID-19. Let's take a look at the role of smoking. Smoking and COPD are known to be associated with higher expression of ACE2 receptors in airways. So more facilitation of virus and more severe infection. More than 50% of Chinese men smoke, while less than 3% of Chinese women smoke, according to Chinese CDC. In Italy, around 7 million men smoke compared to 4.5 million. And in both these countries, there have been significantly higher proportion of men dying from COVID. Some of the gender-based difference in mortality may be explained by smoking. However, in Spain, there is no significant difference between men and women who smoke, yet there is a profound male bias in severity of COVID-19 infection. How about behaviors and habits? Men are more likely to practice unhealthy habits, and surveys suggest that US men are less likely to wash their hands and less likely to use soap. Women are less likely to engage in health-related risks, and they are better at washing their hands. So to conclude, difference in COVID-19 disease severity and mortality in men and women is real and has been noted worldwide. Even after adjustment of socioeconomic factors, occupational and other risks, the gender-based difference persists. Genetic factors leading to a more robust innate immunity and a balanced cytokine response, plus a presence of fewer organs which support replication of SARS-CoV-2 may all contribute to lower mortality in women. Habits and hygiene do matter. Smoking, hand washing, personal hygiene, and adhering to protective measures may all contribute to risk reduction and therefore overall mortality. Thank you very much for your attention, and I apologize for the disruption.
Thank you, Dr. Bushra Jamil. Very nice presentation. So it's not a good news for a male that it has a high mortality in male, as you mentioned, especially from the AQH data. That is a high mortality, and especially this virus hides in the testes. I am surprised. This is also a very bad news. That is, it hides in the testes, and it is present in the semen. And also, it's a very important message for the males or in the society that, guys, please quit smoking, and you have to wash your hands. Please adopt good hygienic measure as like a female as your female counterparts. So very nice presentation from the panelists. If they would like to ask any one or two short questions from Dr. Bushra Jamil. If there are no questions, then we are moving towards our next presentation. Our next presenter is Dr. Majidah Abdul Fattah Bukhari. And Dr. Majidah is working as consultant gastroenterologist at International Medical Center, Jeddah, Saudi Arabia. And she's going to discuss about IBD and pregnancy during COVID-19. Dr. Majidah.
Hello, everyone. Are you able to hear me and see my slides?
Yes, Dr. Majidah, please.
Hello, everyone. It's a pleasure to be here today with all of you and to be part of this great webinar. We have really short time, so in this coming 7 minutes, I will hope to cover the risk of COVID in pregnancy and management of IBD in pregnancy, and then we will conclude with the take-home messages. So pregnant women at the greater risk of getting sick from respiratory viruses, which can lead to adverse events for both the mother and the baby. There are no data showing that the COVID affects pregnant women more differently than other, and the clinical manifestations of COVID-19 in pregnant are similar to those who are non-pregnant. Vertical transmissions of COVID during pregnancy is unlikely. However, there are a small number of babies who've been tested positive for COVID shortly after birth, but it's not clear how did they get the virus, before, during, or after birth. Infected pregnant women who develop pneumonia or get the virus on the late pregnancy are at higher risk of preterm birth, cardiomyopathy, and C-section. So what about IBD? Are they at high risk for COVID than others? So we all know that the elderly patients with comorbidity and people on immunosuppression and biological therapy at the greater risk of severe infection. Despite the potential risk for COVID exposure in IBD patients, the limited available data and experts' opinion suggests that IBD patients do not have greater risk of COVID than other populations. So how do you manage IBD in pregnancy? We all know that the course of IBD during pregnancy is determined by the disease activity at the time of the conception. So if the patient is in remission at the time of the conception, they are likely to be in remission during pregnancy. Whereas 70% of patients who are in active disease at the time of the conception, they will continue or worse their symptoms during pregnancy. So how do you manage IBD during the pandemic? So the AGA International Consensus Meeting and IO-IBD divided the IBD patients into 3 categories. IBD patients who's not infected with COVID-19, IBD patients with SARS-CoV-2 positive, but they are asymptomatic, or IBD patients with confirmed COVID-19, regardless of their disease activity. So how do you manage IBD in remission during pregnancy with no COVID? So all pregnant women, they need to be followed for the whole pregnancy. They need to monitor their IBD by regular visits in each trimester. They need to have regular lab work. They also have to have routine antenatal care, examine the fetal growth on the 3rd trimester, look for the prenatal for any active disease, and counseling them for the mode of delivery. In general, most of these patients, they are recommended to stay on the same therapy and encouraged to be adherent to their therapy. They also need to practice strict social distancing, working from home, and they have meticulous hand hygiene. If they are on biological therapy, they have to continue their biological therapy throughout the pregnancy without interruption. There is no increased risk of complication after 24 weeks, and there is no risk of the infection to the infant up to 1 year. Switching biologic from IV to injectable therapy is not recommended, and also switching to home infusion is not recommended. So what about active IBD during pregnancy without COVID? So first of all, in those populations, you need to confirm the cause of the flare by performing an endoscopic approach, looking for high CRP, high fecal calprotectin. You need to rule out enteric infection with the C. diff and GI pathogen. You only need to do endoscopy in urgent and emergency situations. You need to follow them regularly every 2 weeks, either virtual, online, or by the phone, to adjust their medications and monitor their lab work and the drug level. They also have to be seen by the obstetricians. They need also to look at their nutritional status and counseling them with regard to their mode of delivery. So the treatment of IBD flare during pregnancy without COVID, it depends on the symptoms. If they have mild disease, then you should consider topical therapy, oral budesonide, and symptomatic therapy. But if they have moderate to severe flare, then you should treat them as you would normally to avoid hospitalization, complication, and need for surgery. And you should consider avoiding thiopurine, methotrexate, and tofa in those populations. So what about oral steroids in active disease? We all know that the COVID is associated with cytokine releasing syndrome, and the use of steroids is controversial. Experts suggest to avoid steroid during the COVID pandemic. And if they really need to give steroids, you give the lowest dose, less than 20 milligram for only a short period of duration. What about IBD patients who is infected with COVID, but they are asymptomatic? There are no data showing that people on immunosuppressive therapy are at increased risk of complicated COVID or risk of poor prognosis. So you have to weigh the risk of IBD flare in the course of the COVID in those populations. The use of thiobarine, methotrexate, and tofa are associated with decreased level of CT4 T cell, which associated with longer virus clearance time and more severe course. So in these populations, you should actually hold the thiobarine, methotrexate, and tofa for 7 to 14 days after clinical recovery. And if they are on biological therapy, then you should hold it for 2 weeks while monitoring for development of COVID symptoms. What about IBD patients with active COVID without flare? So this is the most challenging category group. So you should actually treat them according to the severities of COVID infections. If they have mild COVID infection, they are not required hospitalizations or they hospitalized, but their amount of oxygen saturations is good and they do not require ventilations, then you should taper the dose of steroid to less than 20 milligram or switch to budesonide. Continue with 5-ASA, budesonide, and rectal therapy and enteral nutrition. And again, hold thiobarine, methotrexate, and tofa. And if they are in biologic, so you have to delay the biological therapy for 2 weeks. If they have moderate or severe infections where they required mechanical ventilations or pressor, or they have end-organ therapy, then you have to involve the ID specialist to consider treatment for COVID, and you actually continue with tapering the steroid and switch to budesonide and continue 5-ASA, budesonide, and rectal therapy. Again, hold thiobarine, methotrexate, and tofa, and hold the biological therapy 2 weeks. And you have to focus on the life support and treatment for COVID with anti-inflammatory, anti-cytokines, and antiviral therapy. So the other questions, when should we start IBD therapy after COVID infections? So the result from the international consensus meeting, they recommend to restart after 14 days if they do not develop any COVID symptoms or after COVID symptom resolve, or if they have 2 negative nasopharyngeal PCR. So in conclusion, IBD without COVID should not discontinue their IBD therapy and should continue scheduled infusion at appropriate infusion center. IBD with positive COVID-2 but asymptomatic should hold the thiobarine, methotrexate, and tofa, and dosing of biological therapy should be delayed for 2 weeks while monitoring the symptoms of COVID. And in IBD with active COVID should continue hold thiobarine, methotrexate, and tofa, and biological therapy until the viral illness is cleared. The severity of COVID and the severities of IBD should result in careful risk-benefit assessment regarding the treatment for COVID and escalating the treatment for IBD. Pregnant women are not different from other. They are at not risk of COVID, and there is no risk of birth defect and no risk of infections in the newborn. Thank you so much for your attention.
Thank you, Dr. Majidah. Wonderful presentation. And it's a very important topic for females and female gastroenterologists because COVID infection is increasing day by day. And we have lots of female IBD patients. It's a very important topic. Thank you, Dr. Majidah. If anyone has some questions, 2 or 3, you can ask from Dr. Majidah Bukhari. So if we don't have any questions, we can take questions at the end of the session. So our next presentation is by Dr. Professor Eun Young Kim, Consultant Gastroenterologist at University of Daegu and Daegu Catholic Medical Center, Korea. And she will be discussing on very important topic. It is not only related to the female gastroenterologist, but also male gastroenterologist, is resumption of gastroenterology practice during COVID-19 pandemic. And this is very important topic regarding gastroenterologists, male or other male or female. Dr. N.
Okay, thank you, Nazish. Can you hear me?
Yes, we all hear you.
Okay, good evening and good morning, maybe somewhere. This is Eun Young from South Korea. It is my great pleasure to have a chance to talk in this fantastic event. The title of my talk is Resumption of Gastroenterology Practice During COVID-19 Pandemic. I'm going to share my experience with you all. In December last year, pneumonia outbreak occurred in Wuhan, China in January 30th, WHO declared public health emergency of international concern. The first COVID-19 case of Korea was 35 years old Chinese woman from Wuhan who arrived at Incheon Airport on January 19th. About 1 month later, exponential increase of daily new confirmed cases were noted in Korea during end of February and early March. As of yesterday, 11,402 cases of COVID-19 were confirmed in South Korea. Among them, 60.6% were diagnosed in Daegu City, where I live. Ever since the first case of COVID-19 in Daegu was reported on February 17th, our hospital had implemented a rigorous rule of wearing facial masks and frequent hand washing for all healthcare personnel in the hospital, including endoscopy unit. However, on February 27th, one of the nurses in the endoscopy unit was diagnosed with COVID-19. It was not a hospital-acquired infection, but the exact route of infection is unknown. And endoscopy unit was then closed and was reopened on 2nd of March. During the shutdown period of endoscopy unit, meticulous disinfection process was carried out. All doctors and nurses were tested for COVID-19. Phone calls were made to patients to notify the situation and postpone their procedures. Endoscopy is a high-risk procedure for COVID-19 transmission. Person-to-person transmission, respiratory droplets, aerosols, body fluid contacts are all possible transmission routes. Before resumption of endoscopy, we should focus on both safety of the patient and the safety of the healthcare providers. First, check the facility and the human resources available are needed. And should think about how to reduce the workload in endoscopy and how to reschedule the cases that have been postponed. Because our endoscopy unit does not have negative laminar flow room, we decided to open only one endoscopy room which has large windows. Though the test results of COVID-19 of all nurses of our endoscopy unit were negative, self-isolation at home for 2 weeks were enforced because all nurses in the endoscopy unit always had lunch together with the infected nurse. So we invited nurses from endoscopy suites in Health Promotion Center to help us because Health Promotion Center was closed for a while due to COVID-19 outbreak. All GI doctors had negative results of COVID-19 test. We needed to classify the endoscopy procedures to select only emergent and urgent procedure to perform. Urgent endoscopic procedures included active GI bleeding, perforation, biliary sepsis, foreign body removal, care of cancer patients, such as stenting for malignant obstruction. Before the procedure, patient risk stratification is also necessary. At the reception, all patients should wear masks and body temperature was checked and were asked about COVID-19 related symptoms and contact history. Healthcare providers should wear enforced personal protective equipment when performing endoscopy for high-risk patients. After the procedure, patients wear masks if PO2 is above 95% with room air. Healthcare providers should follow the correct steps to take off personal protective equipment. Endoscopy room was cleaned and disinfected after each procedure. Full standard reprocessing measures of endoscope was followed. At the end of the day, cleaning and the disinfection of the entire endoscopy unit was done. This is guidelines of Korean Society of Gastrointestinal Endoscopy for operating endoscopy unit during COVID-19, all written in English, in Korean, sorry. KSGE distributed this to the members of KSGE as a newsletter via email, and poster version was also sent to them. In addition to endoscopy suite, operational reorganization of the hospital GI activities is mandatory. Oh, sorry. Oh.
Slide is not changed. Bilal, please check if there is any technical issue. I think Dr. Kim, I think we have slide again.
No, it's okay, Nazish. I can see the slides.
Okay. Dr. Ann, you can continue.
Dr. Ann, please continue.
Okay.
It's okay. I can see the
It's
slides.
okay?
Yeah.
Oh, sorry. I thought you cannot hear me. Okay, I
No,
will
no, no.
continue.
It's okay.
Okay.
Continue. Yeah.
Okay. In addition to endoscopy suite, operational reorganization of the hospital GI activities is mandatory based on the protection strategy of the whole hospital. There are several reasons. We gastroenterologists can be directly involved in the management of COVID-19 patients as a doctor of internal medicine. Urgent GI consultation still exists. Medical treatment for IBD and GI or hepatobiliary pancreatic cancers should be continued. Recently in Korea, situation is getting better, and we hope to go back to the pre-COVID-19 era, but there is still increase of new cases, especially in Seoul metropolitan area recently. So we are worrying about that now. However, I believe we can win this battle and hope we all can stay healthy to the end of this pandemic. Thank you for listening.
Thank you, Dr. Ann, for very informative talk. I guess there's a problem with Nazish's connection, so I'll take it from here. Now, I would like to invite our panelist, Dr. Nantali, who is currently working as an associate professor in Siriraj Hospital, and she's the director of WHO Training Center. And Dr. Simon, who is currently working as a consultant gastroenterologist and researcher in Brazil, and Dr. Amrita, who is currently president of Women in Endoscopy and working in Columbia University, for the expert review and comments so that we can wind up.
Okay. I'd like to comment on the resumption of endoscopy service in follow-up of Anne's talk. In Thailand, which right now we are doing much better in terms of the new cases of COVID, we have less than 10 new cases per day. So we had resumed our endoscopy. Now we're doing both emergency, urgency, as well as a lot of elective procedures. We have not yet started screening colonoscopy or surveillance colonoscopy just yet, but I think we are going to be doing that very soon. Because we don't have that many new cases, so our strategy is to screen our patients by just questionnaire, and if they fall into high-risk patients, we would then do the COVID test. But I'd like to hear from Simone, from Amrita, where they have lots of new cases still, about their strategy of screening patients before doing endoscopy.
Thanks,
In
Nanta.
Brazil, we in my institution, actually not in we have been following the strategy of answering, and if there is a risk, suspicion of disease, we test the case in our institution. This is what we are doing.
Thanks. Yeah, so currently where we are still high prevalence in New York, at least at our institution, we are testing everyone within 72 hours of the procedure, as well as giving the screening questionnaire. We try to encourage that the test be done prior to arrival at the endoscopy center, so hopefully before, not the day of, in order not to allow for contamination of the endoscopy suite if the test comes back positive. If patients do need to have a test done at our center on the day of the procedure because they live far away or they don't have testing facilities near them, then they get the test done, for example, in the lobby, and are actually not permitted to come up into the endoscopy suite until the result is back. The question comes down to if a patient tests positive, should we still proceed with the procedure in our unit where we have availability of a COVID-19 room? And that really comes down to the urgency of the procedure. If it is an urgent or semi-urgent procedure, or there could be adverse event outcomes if the patient continues to have a delayed procedure, then I think that's something that's taken into account. The patient gets taken directly up to the room, and the entire admission procedure recovery happens there, and then they're discharged home from the room itself, again, in order to try to decrease the amount of contamination that could potentially happen. But in general, we are testing everyone, and we are trying to not to continue to delay procedures on patients who are positive. I think this could be a problem for centers or areas, particularly community practices, private practices, as we start to reopen that don't have availability for testing. And this is really a question of debate. And I think ultimately comes down to prevalence. So as we remain in centers of high prevalence, this is what we need to be mindful of. But as your community, I think, drops its prevalence, I think when we have more chance to sort of change those policies.
And what kind of test do you do, Amrita? Are you doing RT-PCR or rapid test?
Yeah, we're doing the nasal swab.
Okay.
Yeah, the rapid test.
Hi, Amrita, I have a question. So how soon can you get the PCR or testing result? So because if you have a pancreatic cancer, the cholangitis or CVD stone, we don't have time to wait, right? So in that case, how should I do?
Yeah, so I think we do have test formats that are available where the results are available within 2 hours. However, if a patient is a suspected, like a person under suspicion or positive, and it is a case of cholangitis or CBC stone, for example, those are patients that we will still do, but we will treat as if they're COVID positive and do them in a negative pressure room. We have a designated room for COVID positive or suspected patients. I think the tricky part is if a patient has tested negative before, is there any risk of then doing that case in a COVID positive designated room? I think that's something we have to determine. If a room has not had a COVID positive patient and has been cleaned thoroughly with enough cycles, and I think that's a safe space to perform such an emergent procedure, even if the patient is not confirmed positive yet.
Amrita,
I just want to add one thing, and taking this point further, that even if first test is negative, we still need to be very cautious because there is false negative. And still we have to do it with all the precaution. Though negative ventilation room is not mandatory, but again, we need to wear the full PPE kit and everything, and we need to be very cautious because there is 30%, almost 30% chance of false negative.
Yes.
With one test.
So I would like to thank you all our esteemed panelists and our presenters. They have given wonderful and very informative presentations regarding COVID-19, endoscopy, IBD, pregnancy, and the female. So I would like to thank all of you guys and all the participants and all the followers on Facebook. They have commented us very good, and it's a very nice session. So So thank you all. And I would like to end this session because we have, it's 7 p.m. in Pakistan. So thank you guys. Inshallah, we arrange some other webinar on the same topic or some related topics in the near future. Thank you guys.
Thank you all.
Thank you.
Thank you all.
Thank you. Bye.
Thank you. Thank you for joining, everyone. Thank you for making it a successful webinar. Thank you.
Thank you.